welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Morgan Stephenson, who is a PGY2 emergency medicine resident at Stormont Vail Health. She will be presenting a journal club on methylene blue and metformin intoxication, not just rescue, but also initial treatment. Thank you.
Thank you so much for that introduction. And this journal article came from the Pediatric Emergency Care Journal and was just recently published here in November of 2024. And so just a little bit of background information on metformin. I'm sure we're all very friendly with this one, but it is a biguanide, which is a class of medications that's used in diabetes management. It acts by decreasing gluconeogenesis and increasing insulin sensitivity. Gluconeogenesis being, the process of creating glucose from non-carbohydrate sources such as fats, proteins, and the breakdown of those products. And then some side effects of metformin. We're all very aware of the diarrhea. Everyone complains of that. Vitamin B12 deficiency and lactic acidosis, that being the big topic of the discussion today. A fun fact is that in 2022, there were an estimated 19,536,027 patients in the United States that were on metformin. That was a total of 86,747,907 total prescriptions for metformin written in the United States. So here is just a quick little image of how metformin works. I'm going to break it down a little bit here in the next coming slides. So a little bit of background on metformin-associated lactic acidosis. So there are three large ways that metformin can lead to lactic acidosis. So the first being that it inhibits enzymes involved in oxidative phosphorylation. It inhibits the mitochondrial glycerophosphate dehydrogenase and complex 1. The inhibition of those two enzymes causes a decrease in our mitochondrial ATP production, which leads the cell to go into glycolysis, and that leads to a rise in lactate production. So flipping back to this picture, you can see here that complex 1 is circled on the far left, and then the mitochondrial GPDH is circled there in the middle. And then next, it also can cause lactic acidosis by activating guanylate cyclase. And this releases nitric oxide and results in our vascular smooth muscle relaxation, which leads to hypotension, which that in itself can also lead to the production of lactic acid. This is due to an oxygen consumption and delivery mismatch, which the body attempts to correct by initiating anaerobic glycolysis. So for those of you who took any of our main science classes a long time ago, biology, chemistry, etc., here's a reminder of what glycolysis looks like. And then the last way that metformin can lead to lactic acidosis is actually kind of just like the vicious cycle repeats itself. So an accumulation of lactic acid can cause circulatory collapse as well as tissue hyperperfusion and hepatic dysfunction, which that itself increases lactic acid production. So when we're looking at it from a hypoperfusion, circulatory collapse picture, that's typically thought of as type A lactic acidosis, which is again due to that oxygen delivery and consumption mismatch, which then leads to anaerobic glycolysis. So the mismatch of oxygen consumption and delivery is classified as type A lactic acidosis. However, since it's the metformin that's causing this, typically classify metformin-associated lactic acidosis as a type B lactic acidosis, which is defined as a lactic acidosis that has nothing to do with hypoxia or hypoperfusion, commonly due to a medication or a disease pathway such as liver failure, malignancy, or mitochondrial myopathy. Some sources will say that metformin-associated lactic acidosis is actually a combination of a type A and type B, but by definition, it would match mostly a type B lactic acidosis. So our typical management includes supportive care and resuscitation methods, and those resuscitation methods include but are not limited to ventilation, circulatory support, and then renal replacement therapy to remove the metformin from the system. In the majority of the cases in which renal replacement therapy is indicated or warranted, inadequate perfusion must first be corrected in order to actually see a benefit from the renal replacement therapy. So the incidence of metformin-associated lactic acidosis is about 2 to 9 cases per 100,000 person years. However, the mortality rate, it used to be significantly higher. They would say closer to 50%, but in a recent study, they found that it was around 36.2%, which is still a lot higher than we would like to see it. So this high mortality rate does lead to the need for studying and looking into other ways to treat metformin-associated lactic acidosis in order to try to get that mortality rate down. So some previous studies that looked into metformin-associated lactic acidosis, specifically looking at pediatric patients or like doses that could lead to this acidosis and hyperlactatemia. The first one was a review of 55 pediatric patients, and they found that on average, their patients were exposed to around 1,700 milligrams of metformin, and that did not lead to a lactic acidosis in their study population, but they were not able to find an exact toxic dose or recommend anything in one way or another. They just said that it leads to a dose-dependent hyperlactatemia and acidosis. So that led Cassisi and colleagues to do another look, and they looked at 22 acute metformin overdoses in patients ranging from the age of 1-year-old to 18 years of age. They did have 6 patients that required renal replacement therapy. However, they recommended any patient who took more than 15 grams of metformin to be considered as a good candidate for renal replacement therapy, whether that be hemodialysis or continuous renal replacement therapy, and that all patients who have metformin-associated lactic acidosis be closely monitored, as it can be highly fatal, and patients' clinical picture may change rapidly when they are experiencing this lactic acidosis. And then lastly, I wanted to bring in this meta-analysis from Bloomberg and colleagues, and they were looking at 44 studies. So they were able to find 170 cases of the MALA. Unfortunately, they were looking at older patients, so not necessarily the group of patients that we're looking at today, but their median age seemed to be around 68.5. They found that the median pH of 7.02 was found in their patients, and that a median lactate of 14.45 was what they found in their 170 cases. However, looking at predictive power of lactic acid and pH, they found that there was actually a very poor predictive value. Things to consider from this meta-analysis are that many of these patients also came in with comorbidities such as renal failure or sepsis, and so that could not only increase their lactic acid in their serum, but it could also have, given some sort of played a part in their mortality. So it's not just to say that the MALA was what led to their mortality. And so then now let's talk about methylene blue. So there have only been a few studies looking at methylene blue in metformin-associated lactic acidosis. So the first one, they are all case reports or case studies. So the first one was Plum and colleagues, and they were looking at a 66-year-old who had shock, nausea, and vomiting, and they classified them as being hemodynamically unstable despite fluids, inotropes, and renal replacement therapy. Upon initiation of methylene blue, this patient did recover rather rapidly, and they were able to discharge from the ICU as well as the hospital in total. So then Graham and colleagues looked at a 44-year-old who had distributive shock following an intentional metformin overdose. They again started with fluid resuscitation, then moved on to vasopressors. The patient was hypotensive refractory to both of those efforts. They started methylene blue, and this patient also recovered. Heredia and colleagues looked at a 6-year-old who had shock refractory to the large fluid bolus and vasopressors. This patient also was a metformin-associated lactic acidosis patient, and they also received methylene blue and were able to recover. The last case report or case study looked at 17 different cases. So 10 of them were calcium channel blockers, 3 atenolol plus amlodipine, 5 were metformin, 1 ibuprofen, and 1 multi-drug. That included many antipsychotics. 9 of those patients had hemodynamic improvement following methylene blue administration, but a handful of them were not the metformin patients. So we can see here that methylene blue can help in those last line refractory hypotensive patients. But as I was digging into this, I was like, that's really interesting, but there's not a lot of things looking into it. So a little bit about why methylene blue works and what it does. So methylene blue promotes mitochondrial respiration. counteracts the nitric oxide-induced vasoplegia by inhibiting guanylate cyclase. So nitric oxide promotes vasoplegia by enhancing the guanylate cyclase cyclic guanosine monophosphate second messenger system. And methylene blue comes in and is able to block that action, allowing for vasorelaxation. And then some side effects of methylene blue. So hypertension, tachycardia. You can also see seizure-like activity, increases in liver enzymes are things to be concerned about. The other thing that I wanted to call attention to is that this medication must be administered slowly for a couple of reasons. One being that it has a high likelihood of extravasation, and the other being that it can increase, like a large amount in one area can increase the hemoglobin in the body or in that area. So it is also recommended to administer via a central line to try to avoid those things. If a patient does have an extravasation event, you stop the infusion immediately, leave the needle in place, gently aspirate any of the extravasated solution that you can, remove the needle, elevate it, and then apply warm and dry compresses. There have been a couple of people looking into using phentolamine or nitroglycerin ointment for those patients as well. So now onto our case. It's another, like I said, another case report. So we had a 16-year-old female admitted to the emergency department. She reported ingesting about 40,000 milligram tablets of metformin. They did gastric decontamination procedures in the emergency department. All of her initial vitals were within normal limits for a 16-year-old female, and her lactate concentration in the emergency department was 2.5. She was quickly transferred to the PICU for closer monitoring. However, within an hour of transfer to the PICU, her vitals were as follows. Her blood pressure became 75/30. Heart rate was 160 beats per minute. Respiratory rate was 26. Her temperature was 36 degrees Celsius. Her O2 saturation was 91%. Her lactate had increased to 10 millimoles per liter. And then her VIS score, or vasoactive ionotrope score, was 50. So for those unaware, the vasoactive ionotrope score is a way to look at a patient's vasopressor requirements. So it's fixed values looking at your vasopressin dose, epi dose, norepinephrine dose, methylene blue dose, milrinone dose, phenylephrine dose, angiotensin doses, dobutamine, and dopamine doses. Generally, these scores fall between 0 and 100. The higher the score indicates a greater vasoactive and ionotrope need in these patients. So hers was 50, leading us to believe she had a high need for those medications. She also at one point developed ventricular tachycardia. She did have to be immediately cardioverted due to the hemodynamic instability that she was experiencing, and they were able to restore normal sinus rhythm within 1 minute. Sorry, not 1 hour, 1 minute. Following cardioversion, they started rapid fluid boluses, try to equal 30 mils per kilo. They also did norepinephrine, which was at 0.2 mics per kilo per minute, epinephrine, which was started at 0.3 mics per kilo per minute, and a sodium bicarb drip. As those were not improving the patient's hemodynamic status, they also started CRRT with continuous veno-venous hemodiafiltration. And then following that, they were still hemodynamically unstable, and they started a dopamine drip and dobutamine. Dopamine was at 10 mics per kilo per minute, and dobutamine was also at 10 mics per kilo per minute. So despite their maximum treatment efforts, her hypotension continued to it was refractory to all of these efforts, and her lactate level continued to climb. Unfortunately, they did not say how high it got, so they just said it did continue to persist. So they, at this point, initiated methylene blue as kind of a salvage therapy for this patient. So they initiated it at 1 mg per kilo as a bolus over 60 minutes, followed by a continuous infusion of 0.25 to 2 milligrams per kilo per hour. They were able to see hemodynamic improvement within 30 minutes of initiation, and they were able to take her off of CVV HDF on day 2 in the PICU, so after about 24 hours on this methylene blue, and then they discontinued methylene blue on day 3, and she was actually able to be discharged on day 5. They also stopped all pressor support on day 2. I believe I missed saying that. So just some discussion. So given previous knowledge of metformin's mechanisms of toxicity, and looking at methylene blue's mechanism of action, it can be assumed that there would be a potential benefit in patients who are experiencing especially hemodynamic instability due to the metformin-associated lactic acidosis. Based on previous studies that I mentioned, which were all case studies, I should say, the dose was chosen to be 1 to 2 mg per kilo as a bolus over 60 minutes, followed by that continuous infusion rate of 0.25 to 2 milligrams per kilogram per hour. They did see rapid improvement in hemodynamics in this patient, which matches what was seen in the previous case reports in the older patients as well. Currently, there's no specific data around methylene blue and CRT and whether it's cleared or not. So things that make me think that CRT would help clear methylene blue as well. It has a molecular weight of 3.1 or 319.9, Daltons, which is considered small on the scale of molecules. Dialyzability is determined by the size of the drug molecule in relation to the pore size, and generally those with lower molecular weights are able to pass through that membrane. It also is highly protein bound. Unfortunately, that does work against it when it comes to dialysis, as things that are highly protein bound usually are not dialyzed. The volume of distribution of methylene blue is relatively low at rounded like 0.9 liters per kilogram, meaning it is also likely to be dialyzed based on its volume of distribution, as it's not distributing into all of the other accessory tissues. And it is water soluble, making me think that it would be pulled out in the dialysis solution, and that it also will not be, like I said, distributed into other tissues such as a lipid soluble drug would be. One study did find that a patient who was receiving methylene blue while undergoing CRT did have green effluent solution, which also leads me to believe that it would be dialyzable. And then our patient did have improvement in their hemodynamics despite being on CRT, because they were already on CRT and were still hemodynamically unstable. And so the addition of methylene blue improved their hemodynamics despite it also potentially being cleared by the CRT. So there are a few case reports that apply methylene blue to the metformin toxicity. All of them focus on methylene blue being able to reverse the nitric oxide-induced vasoplasia, which is what it's been studied for in other settings as well. If we think about patients who, there's a study looking at patients who undergo CABGs or a cardiac bypass surgery, and they looked at the use of methylene blue in those patients who experienced vasoplasia after a CABG, and they found that it was able to reverse that hypothesized nitric oxide-induced vasoplasia. And those patients, they've also looked at it in a handful of other cardiac settings as well as anesthesia settings for the same thing. These authors believe that due to its effect on oxidative phosphorylation, that methylene blue could also decrease lactic acid production, not only by reversing this nitric oxide vasoplasia that can lead into that vicious cycle of lactic acid production, but by also helping with the guanylate cyclase, And then they concluded that early and concurrent treatment with methylene blue could be used as an initial approach based off of hypothesizing its benefit based off of its mechanism of action. So in conclusion, methylene blue has not only been shown to be beneficial as salvage therapy, but could also have a place as initial therapy in metformin toxicity. Some things I wanted to touch on, some limitations to this study, were that it first did not actually provide the weight of the patient. Unfortunately, that makes it hard in a setting in which we're looking at doses on a milligram or microgram per kilogram basis. So we're looking at weight-based doses. Not knowing the exact weight of the patient leads me to not knowing the actual dose that the patient was getting. So those, I think, would have been beneficial, but it wouldn't have changed my thoughts on this. It also did not mention in the article whether the patient took extended release or immediate release metformin tablets, which would also potentially be something to look into, as well as could sway our treatment decisions in one way or another. Some strengths I thought were that they really tried to use it as, like I said, as salvage therapy. They had tried everything else for this 16-year-old and nothing was working. So I think they did a good job showing that it could be used in that place. However, their conclusion that it could have a place in initial treatment, as they didn't utilize it in that way, I don't necessarily think that that's a fair conclusion for them to make. So in my opinion, it does have a spot in treatment as potentially salvage therapy, or for patients who are refractory to our typical fluid, bolus, and vasopressor treatments. I don't necessarily think that you have to get all the way down the line like they did to be throwing like dopamine and dobutamine at someone before utilizing it. I definitely think it has a place prior to that, but I would need to see more to utilize it as initial therapy, especially in a pediatric patient. So I would like to give a big thank you to Laura Carson. She is my RPD, and she helped me with this presentation by, listening to me talk to her. So any questions or thoughts?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.